I just wanted to discuss a little bit about the incidence of neuroendocrine tumors. I'm sure you're very familiar and you have seen these slides many times, but as you can see here, in terms of the incidence of neuroendocrine tumors, we can see that this is the blue line is all other cancers that are not neuroendocrine tumors, like colon cancer, breast cancer, colon cancer. But as you can see here, this orange line, this is the incidence of neuroendocrine tumors that has increased quite exponentially over the last few decades. And you may ask yourself, why is that? Why we see an incidence of neuroendocrine tumors? And one of the things is because we have better diagnostic tools as well to diagnose neuroendocrine tumors. At the same time, there is an ongoing research question whether these epigenetic changes may be causing this as well. So that's some of the questions that we want to answer as part of the increased incidence of neuroendocrine tumors. We also see that there is an increased incidence of neuroendocrine tumors by site as well, between the GI and small intestine, pancreas, as well as the lung neuroendocrine tumors. And also, in terms of the treatment landscape for neuroendocrine tumors, before 20 years ago, there were not that many options for the management of neuroendocrine tumors. That said, over the last 2 decades, we can see there has been now an explosion of the different therapies of neuroendocrine tumors. That said, I do want to make a comment here, because even though that has been our experience in the United States, that's not the same for other part of the world. And I think there is so much work that needs to be done in terms of accessibility to drugs, not only in different areas of the country, but that's something that one of the efforts I'm hoping that we could work together is to also have accessibility to drugs in other part of the world when they don't have access to. Now, so the topic was about practice change in clinical trials, and I have to say that one of them is about the Netherlands study, which that was the Lutathera study, 177 lutetium dotatate, and this has been the study, the landmark study that led to the approval of 177 lutetium dotatate Lutathera for neuroendocrine tumors. And as we can see here, so for those that are very familiar with the Kaplan-Meier curves, so we can see that there is a significant benefit on progression-free survival, as we can see here, compared to the long-acting octreotide. But that say, in the final analysis of the study, there was no benefit on overall survival, but that's questionable, because one of the questions were the study was powered for this, for the endpoint that we wanted to answer. But also to keep in mind is that there was a difference in terms of median overall survival compared to the placebo group, as we can see here, and that's kind of like about the median of almost a year that may be considered clinically meaningful for those patients with neuroendocrine tumors. But that said, there is still room for improvement, and we know that we need better therapies for neuroendocrine tumors. We know that we need to improve also the quality of life as well with patients with neuroendocrine tumors, and we know that there are different challenges. We know that there is few FDA-approved agents, even though there has been many different treatments approved over the last 2 decades or so. Still, compared to other solid cancers, like breast cancer and colon cancer, I have to say that we still have very few treatment available for neuroendocrine tumors. But also the question is like when or what combination therapeutic approaches should be used. I think one of the questions is about sequencing of therapies. So we know that neuroendocrine tumors require a multidisciplinary team. Every neuroendocrine tumor is different, and usually the treatment approach of the recommendations, it may be different from patient to patient. And because of that, I think sequencing is one of the questions that we have when to give a specific approach in a patient diagnosed with neuroendocrine tumors. And also how long the treatment should be used. And one of the examples is the combination of capecitabine and temozolomide. Do we give it for 6 months? Do we give it for a year? I think that's also the question that we want to answer. Do we give it for longer time? And I think that's another question that we want to answer as well. And what's the group of patients a particular treatment option should be used? And that's, again, what we discussed earlier, there are neuroendocrine tumors. It could be anywhere in the body. We have different type of neuroendocrine tumors, and sometimes we overlap information of what we have learned from the GI and pancreas, and then we applicable to the lung. But that said, we still need to understand about the benefit of different therapies and different type of neuroendocrine tumors. Now, what will be an answer to those questions? And that's one of the things I have been working, as well as my institution, is that a comprehensive classification system that incorporates tumor clinical stage, genomic and epigenetic alterations, as well as gene expression profile could serve to better define the biology of neuroendocrine tumors, and hopefully that information could establish correlations with clinical outcomes, and with that information we can then develop effective therapies. Now, patients with neuroendocrine tumors and their families face unique challenges. We discussed and we heard earlier that there is a long time to diagnosis, and sometimes when the patients are diagnosed with neuroendocrine tumors are usually in very advanced stages. Most medical centers has limited experience. In the United States, there's very few centers that has limited experience with neuroendocrine tumors, but also other parts of the country like Mexico, South America, or other parts of the countries may not have that experience as well, and I think we heard that many times earlier. And because of that, patients often has to search for expert and potentially require an extensive travel outside the home region, and that comes with a lot of cost and a lot of burden to the families as well. There is no standardized treatment guidance that creates some uncertainty and a search for answers, and because of that, patients often feel isolated. So how we can help with that situation, and I think that's something that has been always discussed a lot, is by developing an easily accessible national and international patient engagement network for neuroendocrine tumor research and patient care with advocacy support groups will definitely help address the needs that we discussed about, as well as increase access to patients to research. And that's where INCA has been doing a very amazing job by doing all of this, and as well, Net Research Foundation with all of the research claim. I think so there are models in order to bring those answers to all those questions, but we still need to work together in order to make a bigger outcome or impact to the patients. So, but also on the other hand, now researchers also face hurdles to developing cures. Number one, based on what we know standardized guidelines about how to run clinical trials, sometimes it takes a long time to accrue patients, especially when they're rare cancers. Sometimes multidisciplinary care are needed as well for patients living with neuroendocrine tumors as well, for those patients that have a cancer predisposition syndrome associated with neuroendocrine tumors as well. Sometimes there is lack of coordination between teams, and that creates silos and that limit efficiency to clinical trials. There is also limited diversity in net cell lines, and there's really no validated patient-derived xenografts. There is some of them, but there's still a lot more work that needs to be done. And also, fundraising for research is quite challenging, and especially for patients with neuroendocrine tumors, and there's less sources for grant funding. And what will be a solution for this? And this is one of the things that I've been trying to discuss now since I've been in these research aspects of neuroendocrine tumors, is that collaborative, well-funded research networks for neuroendocrine tumors will promote development of new therapies and standards for patient care. And that's where, again, patient advocacy, industry, physicians, researchers needs to work together for this same goal. Now, this is a very good example. This is not related to neuroendocrine tumors, but this has been a model that I would like to implement as well for neuroendocrine tumors. At the NIH, at my institution, we have what we call a wild-type GIST clinic. Maybe Stephanie familiar with that, because GIST, especially the wild type, are the ones that are associated with succinate dehydrogenase mutation. There is also association with pheochromocytomas and paragangliomas. This clinic has been going at the NIH for quite a few 15 to 20 years. It's been going on for a while, where basically what they do is we bring patients to the clinical center, but we also work with other researchers as well that has an expertise in this disease type. And over the years, by collaborating with researchers, by collaborating with patient advocacy, but obtaining this very detailed clinical information and obtaining very detailed genomic data, the accomplishment for that has been that now, what we used to know, the wild-type GIST, now we know that has been associated with a mutation. Moreover, it helps us to understand about the clinical understanding of these tumors to the point that now we're able to determine what therapies may work for those patients, but also it helps us to determine the clinical trials as well. With that information, we have been able to develop clinical trials for the wild-type GIST clinic. Again, there are Dr. Hellman, Dr. Glott, Dr. Aldes from NIH were the ones who started this clinic. It's still ongoing, but that's something that I'm working as well, hopefully with the help of all of you, to be able to have something similar, not only at my institution, but also in other centers throughout the world. So in order to achieve that, what needs to be done? How we can work together. And that's where a comprehensive engagement between patients and advocacy that help us then to have a full analysis of the net patients is very important. So we need patient advocacy. That's kind of like the most important part of any clinical trial and any clinical trial development. I sometimes feel that we don't get enough credit to our patients sometimes as researchers, and I think that they are the most important part of the equation, because patient advocacy is the one that's helping us understand more about what the patient's needs are. Once we have this patient advocacy engagement, we can see that there is going to be a series of understanding about the tumor type. And with that, this is one of the things that we want to work together with you, is that we are able to work together as a team, have a series of samples that we can collect, also access to data as well and clinical information, and this is what we have here. And then also with that information, we can collect biospecimens from patients as well, and that will help us to obtain a biorepository and database. This will also help us to disseminate information, as well as be able to create new models. And I have to say, we like to acknowledge NANETS, ENETS, the NERRF, because they're the ones who has been really dedicated for the treatment and research for neuroendocrine tumors. But that said, there is so much work that needs to be done, and there is so much funding that needs to be obtained for these patients as well. But that's kind of like one of my goals as well, to be able to work together with the patient advocacy as well as the patient organizations and industry as well, to be able to collect that information about patient and biorepository that will help us then to develop therapies for neuroendocrine tumors. And thus develop effective therapies. That will be the end goal. Now, I'm a strong believer of the natural history study. Initially, when I started on the Rare Tumor Initiative, that was a Cancer Moonshot funded. It helped me understand the importance of what a natural history study is. And the natural history study helps researchers to collect specific information about the patient, medical history, tissue, tumor samples, and all that information with that correlated with outcomes. That information is important not only to help us understand about the biology of these neuroendocrine tumors, but also whether there could be any prevention guidelines or any clues as well that help me more to understand about precision medicine for neuroendocrine tumors. I think we have a window of opportunity to develop precision medicine for neuroendocrine tumors. I think we're still early on that, but we're now learning more and more about precision medicine for neuroendocrine tumors as well. And that's something important as well, that a natural history study can provide that. I'm fortunate that one of the efforts that and I'm proud of this as well, that I had a natural history study for neuroendocrine neoplasm as well as tissue procurement. This study allows me to collect tissue as well as clinical information of each patient. And this is pretty much the model that we have, and that's I've been working at my institution, is that when a patient is referred to me and is eligible for surgery, so we collect a small tissue from the OR. You always see me around going to the OR as well to collect a little bit of tissue, so that way we can do different studies with that tissue. One thing that we're working is to be able to do a very extensive genomic analysis as well as RNA sequencing and methylation analysis. The goal of that is that with that information, with the methylome data, with the RNA sequencing data, we wanted to understand whether we can find any predictive biomarker, any gene or any protein that help me to understand what patients may do worse over time, but also prognostic biomarker, meaning any protein or gene that help me to understand which patients may benefit for a specific type of therapy. We're also working on organoids too, and NERRF also has a very important role on development of new models, including organoids. And with that, we're trying to do different drug testing. We work with a center within the NIH that has a extensive library of drugs and allow us to test different FDA and non-FDA approved drugs to develop whether it's a signal that we can find to then develop a clinical trial, but also collaborated with other investigators within the clinical center and outside of my institutions to understand about the tumor immune microenvironment. And based on that, be able to understand more about whether within the immune system, if there is a window of treatment as well. We know that immunotherapy is not something that works for the well-differentiated neuroendocrine tumor. That said, we're able to understand more about the tumor immune microenvironment, whether there is a way that we can then stimulate the immune system to get to then make immunotherapy more effective. And this is some of the work that have been done about organoids. We discussed about that. We discussed about the genomic data. We discussed about the tumor immune microenvironment. We also try and work with our Department of Pathology in order to do this artificial intelligence digital spatial profiling to then correlate that with responsive therapy. That said, something that I'm working hard is to be able to develop collaborators, and I have to say I'm working with Rona about that, and to be able to have this partnership as well and be able to have that accessibility to other patients in need. This is a very busy slide. This is the ongoing clinical trials for well-differentiated neuroendocrine tumors. The studies is mainly in the United States, and we can see that there is different studies, not only from grade 1 well-differentiated, but also from grade 3 well-differentiated neuroendocrine tumors, where we have different therapies for neuroendocrine tumors for pancreas as well as for GI and pancreas neuroendocrine tumors. One of the studies that we have available at the NIH is the combination of Lutathera with olaparib, and I'll be discussing earlier as well about that. There is a very interesting combination, and preliminary results seems quite hopeful, but that said, we still need to have a lot of patients to enroll on that. And the idea of doing this study is that Lutathera is a type of radiation. This radiation breaks the DNA of the tumor. And what the tumor or the body is trying to do is trying to prevent that, repair that break, because that whenever our body sends an insult, so the body is just trying to then compensate for that insult. And sometimes when that happens, sometimes we see this resistance to therapies. By adding a drug that can prevent that repair, the question is, could we make Lutathera effective? And that's one of the questions that we want to answer by doing this study. Similarly, we have another study with triapine, and that's the same analogy, but this is the clinical trials available. And again, I have to say, this is what is available in the United States. It's not necessarily applicable to other part of the world, but that said, again, working with patient advocacy, that's something that we can work together as well as industry, because a lot of the studies are industry sponsored as well. And I think they play an important role to have accessibility to drugs as well as develop clinical trials. These are the NCI-sponsored clinical trials, meaning that this is my institution. That doesn't mean that we have every study at the clinical center where I am at the NCI, but what that means sponsor is that the NCI has these drugs available in order to run a clinical study. And usually the drugs that are available is free of cost to the patient. And as we can see, there's different studies, not only for pancreas as well as GI neuroendocrine tumors, but we also have one for neuroendocrine carcinoma as well as for pheochromocytomas and paragangliomas. And I think this model is important, that I feel that model needs to be implemented in another part of the world as well, and I'll tell you why. And that's where I feel modernizing clinical trials is important. Number one, by having this system in place, it can also reduce the financial burden of clinical trials. And I think a lot of the industry and sponsored studies is that they cost a lot to run a study, and because of that, what happened is that there is a high drug prices for our patients. We wanted to break that continuity of high cost of drugs. How we can do that, and that's kind of like what I think that maybe having a decreased trial size. I don't think we're going to have 200 patients for a type of tumor that is not very common. I think that by decreasing the trial size to decrease efficacy, that can definitely cost a lot of the trial costs that then hopefully will then decrease the drug of cost as well. But also, a lot of the studies is like we have this control group, and then we have this placebo control. If we know that there is efficacy to the drug, maybe this is not needed, because that's also add to the cost of the study. So, and I think that that's where we need to rethink about how to do these clinical studies as well, and have more pragmatic ideas. Maybe we don't need to have a lot of primary, secondary, and exploratory objectives. Sometimes we have like a 10 exploratory objectives, and that at cost, but maybe we can extrapolate data, what we have learned from other clinical studies using the same agents, and have more specific questions that we want to answer by doing the study. At the end of the day, we want to benefit the patient. Having a study that can last 10 years is not going to help our patients. Our patients need treatment now. And that's where we need to rethink about how we can run clinical trials. There are also trials that complement industry, and we need to avoid redundancy. I think a lot of our industry people, and I'm sorry, no, please don't take it personal, but I feel like a lot of this is that sometimes when there is a low prevalence of cancers, there is limited commercial incentive, and I think we need to also change that, and we need to work also with our industry in order to avoid some of the redundancy done. I think that it's important to have a discussion with them. There is no need for competition. I think that's something that we need to really talk really hard about, how we can avoid this redundancy and complement the industry in order to make these treatments accessible for patients. And I think at the end of the day, we want to help our patients, and that's where our ethical and moral needs to play. But it's not about what is the cost, and it's not about what can I get in the long term. Everybody's worried about how much money they can make, but at the end of the day, we're talking about patients' life. And I think we need to keep in heart and mind what we need to do and how we can benefit our patients. Sometimes we need to think about, instead of having high doses of a specific drug, maybe we need to lower the dose of the dose of the drug. We need to maybe have some prevention studies, something that we can partner together with industry to complement. It's not for competition, it's to complement what is done and how we can make this accessible and better for our patients. I have to say, and I always take this, theranostic started with neuroendocrine tumors. I know that there is now a big thing about prostate cancer and other solid cancer, but we need to keep in mind it started with neuroendocrine tumors. We learn a lot about neuroendocrine tumors. It's time to pay back our patients for all the work and the suffering that they went through. And that's just my own personal opinion. We can also do trials based on molecular alterations too. This is something that, we, in terms of precision medicine, whether we talked earlier about predictive prognostic biomarker, I think there is a time for also understand more about that and be more specific with less trial size as well. We also need to understand the accrual, increase in accrual, and also keep in mind on our underserved populations as well, and be able to understand more about what the patient's needs are, not only locally, but also globally as well. And we need to also have a patient-centered approach. Sometimes we are very focused about progression-free survival, response rate, overall survival, but how about quality of life as an endpoint? How about trying to understand more about the tolerability? Maybe we need to have a lower dose in order for the patient to tolerate better the treatment. I think we need to rethink about how we are running clinical trials in order to benefit the patient in the long term. So this is, I have to say, I'm proud of being part of this. This is, we're discussing earlier about the TOT, which is Department of Defense research grants. I started this from the very beginning of the inception of this program, which is a part of the program, part of the Department of Defense Congress-supported research. And there's different ideas on how we are supporting research in rare cancers. But that's one of the things that I'm kind of like proud of, as being a part of, that there is a new award which is called the Resource and Community Development Award. And that's basically is applicable for any cancer type, any rare cancer type, but we integrate patient advocacy from the very beginning of the development. And I think that this is something very important in order to move forward with the research studies. And also major emphasis on data sharing with stakeholders. And I think that's something that one of the very important grants where patient advocacy is so crucial and important in order to develop this study and award. In conclusions, progress has been made in the understanding of the pathogenesis and development of therapies for neuroendocrine tumors. There are multiple challenges that remains. Some of them is because we now have better understanding of the tumor pathogenesis, but that said, we still far from undeveloped effective therapies for neuroendocrine tumors. I do believe that they need to be in adult and pediatric collaborations. I do believe that there is a silo between our pediatric patients, especially for those patients that have a cancer predisposition syndromes associated with neuroendocrine tumors, such as MEN1, MEN2A, MEN2B, and MEN4. pheochromocytomas and paragangliomas. I think should be a way also to include the whole pediatric population. I think one of the things that the United States also doing as well, especially at the level of the FDA, is lowering the age of clinical trial inclusion, starting at the age of 12, because we see more and more patients, especially pediatric patients, already has metastatic disease, and I think that's something that we need to rethink about as well. And also, we discussed earlier about the engagement of advocacy groups. We also need to have a better understanding of net pathophysiology that way, and also clinical trial, preclinical models development also help us facilitate development of targeted therapeutic approaches as well. We need to also have sustainable resource that allow to continue research in neuroendocrine tumors, and that's where NRF, patient advocacy, INCA can definitely play a very important role as well to educate and also increase awareness of these neuroendocrine tumors. But one thing is that how we can improve the access to drugs globally. And I know that we have a lot of resources in the United States. Maybe there is other part of the country, but that's not the same for many other part of the world. And I think that's something, a focus that we need to also, as part of patient advocacy, a focus to better outreach of those patients in need. And again, when you ask me about, about what is the in terms of practice changing of clinical trials, I think one of the most important things is that patient advocacy has a critical role in supporting all of the above efforts, but also to improve the patient outcomes and in practice changing clinical trials. And with that, I would like to thank you for your attention.